Oh, sorry. All right, good afternoon, everyone. Good afternoon, everyone. Welcome to the Judicial Proceedings Committee. Today is Wednesday, January 17th. This is our second of 5 or early session briefings. Usually, I'm super cognizant of the time because we have mayors and state's attorneys and public defenders coming to present, and they have really important work to get back to. But today we actually have some folks that do extremely important work, and I don't want to hold them here for longer than they need to be because they literally are saving lives every single day. And so I want to make sure we hear from them, have an opportunity to have a dialogue, but then get them back on their way. So thank you all for the committee members for being here in a timely fashion. Just for some of the context, we're dealing a lot with juvenile justice reform and juvenile crime, and we're going to talk about the intersection between. We had an overview of the juvenile justice system yesterday. We're going to talk about chronic absenteeism and truancy. We're going to talk about crime trends and analysis. But today, we're going to talk about the public health side of gun violence, and we'll talk a little bit about the youth aspect of that as well. But just to set some context, and we had an occasion to talk about this a little bit earlier today down at a press conference, but on average, 796 people in Maryland die from gun violence every year. The rate of gun deaths in Maryland has increased 54% over the last 10 years. The rate of homicides has increased 91% from gun violence over that same course of time. 63% of gun deaths in Maryland are homicide. 35% of those deaths are from suicide. Maryland currently has the 9th highest rate of gun homicides in the country. Guns are the leading cause of death for children and youth in Maryland. And Black Marylanders are 16 times more likely to die of gun homicide than their white counterparts in Maryland. So that's the kind of the backdrop for our discussion today. And obviously, we've focused in. I talk about the role of JPR too often. We focus on kind of the ex post, like the after something bad has happened, something unfortunate has happened, and then so what should the penalty be? How long should someone go to jail? We've also focused on evolving with technology and evolving with developments in how guns are proliferated through our state. So ghost guns is a kind of an important example of that. And we've also focused on community-based solutions. So psychological supports, mental health supports, community-based solutions, violence interrupters. So we'll hear from some of those folks here today as well. But one piece, I thought was really interesting is that we rightfully celebrated recently. You saw a lot of headlines in Baltimore City in particular about a nearly 20% drop in homicides from last year to this year, and the majority of those homicides were from due to gun violence. And if you look at, you'll hear from, our shock trauma folks. You'll hear from Dr. Scalia today, and you'll hear from Nadir Abdullah today as well. He's going to join us through Zoom. That they see anywhere from 600 to 700 people every year from gunshots. And so you put those two numbers together, but for our world-class healthcare system, but for our trauma centers that save countless lives every single year, that number is far worse, and I think gets us closer to diagnosing the actual severity of the problem throughout our state. And so today we're really, really honored to be joined by just some world-class professionals that save countless lives every single year. We have Dr. Thomas Scalia from Shock Trauma Associates, and then we'll hear from some folks from Johns Hopkins University, Dr. Abdullah, to lead us off, and then we'll go through the full panel when we get to it, and then we'll round off our afternoon with a presentation from Center for Hope, and then we'll have time for Q&A. So we're going to hear from all of them, then we'll have Q&A at the end. Unless Doctor, we can get you out of here. So we'll have, after you will present, we can have some dialogue and make sure, if you're time constrained, if you can stick around, then we'll accommodate you. Excellent. I appreciate that. I'm just extremely sensitive to the time constraints because folks here are saving lives every single day. So that's the backdrop for our discussion. And so without further ado, I'd just like to invite Dr. Scalia up to provide us with your briefing, and we'll get underway here. Doctor, welcome.
standing up here in a suit. This is not my usual way of doing things. I can control the slides myself. That's easy for you to say. All right. I am going to break this without any doubt. Okay. Thank you. And I will take about 20 minutes or so, maybe a little longer. And I would like to ask you to indulge me and let me talk a little bit about injury care in general and the Maryland way of taking care of injury as a preamble to talk about exactly about violence. I think it's important that we class injury and violence as what it is, and it's a disease. It's a disease like everything else, and disease is defined as a condition of the living animal or plant that impairs normal functioning. And so, fair enough, we say there are infectious diseases, we say there's heart disease, we say there's a specific disease like pneumonia, and then we talk about diseases like poverty, which is itself, I think, a disease. And trauma is a disease because it affects the functioning of every organ system in the human body, either by direct injury or energy transfer. And even non-injured parts of the body are affected by the consequences of injury, such as shock or infection. It's a huge public health problem, and we have not recognized it to be the public health problem that it is. And we'll go through some of this. And like every other disease, trauma has a prevention strategy. There is a physiology to injury and blood loss. There is direct organ system injury. You injure your liver, you injure your spleen. There's a way to evaluate it, a way to resuscitate it. There is operative care for it. There is critical care, and there's rehabilitation. And if you're the person that is injured, what you want to do is to go from the top of the slide to the bottom of the slide just as quickly and efficiently as possible. And you know, we used to call these things motor vehicle accidents, but these are predictable events. So if you get very drunk and get behind the wheel and drive at 60 miles an hour without a seatbelt, is it an accident when you wreck your car? I'm going to tell you, I think that's a predictable event. Distracted driving, another, recently gotten a lot of press. Geriatric falls, something that now comprise almost 40% of the patients that we see. And violence in young people who live in circumstances that promote violence is not a surprise. It is a consequence of their life circumstances. And we can prevent a lot of injury. We can't prevent everything, right? So you eliminate drunk driving and distracted driving, and then there's still human error, weather conditions. There will be injury, but there's no rule that says that somebody has to pick up a gun and shoot somebody else. These are 100% preventable injuries if we attack them the way that we should be attacking them. And the second point here is that organized trauma care saves lives. This is data from the University Health Systems Consortium. This is patients that had femur fractures and brain injury. And you can see, these are patients with gunshot wounds to the abdomen. And you can see that somewhere around 450 major trauma admissions a year, survival gets better than predicted. It's not 450 gunshot wounds. It's just the mechanics of taking care of patients. This is the same data on brain injury and femur fractures. If you don't have coma, you do relatively well. If you do have bad brain injury, that number is 850 major trauma admissions a year. And this is just data that demonstrates that you don't hang your shingle out and the next day you're operating at maximum efficiency. It takes a number of years to mature a trauma system or a trauma center to the point where there is noticeable decrease in mortality, at least decrease below expected. And injury is a disease where survival is related to the severity of the injury and the duration before you get to medical care. So it's about injury, it's about time. It is the quintessential time-sensitive disease, and this is the Maryland trauma system. It is divided into EMS zones. There is a helicopter stationed in each of the zones. There is a regional trauma center in each of the zones. The MIMS, the Maryland Institute for Emergency Medical Services System, has offices that know where every helicopter is at any given time. There is the ability to call in, and when I'm on call, I am air traffic control for the trauma system. And the level of organization is frankly unparalleled. It's a pyramid where if you're not badly injured, you don't need to come to Baltimore. You should stay near your home and you will get perfectly good trauma care in any of the regional trauma centers that are dotted around the state. But if you are terribly injured, you want to come and you want to land on our roof. And these are helicopter flight times. The Maryland system is so efficient that from injury to touchdown of the helicopter is 18 minutes and 43 minutes. Do that math. That's the longest helicopter ride. The golden hour is a very real thing. You can fly over the mountains. You can fly over the water. This is what you get by living in the state of Maryland. You get access to this level of care. And this is the old building, the old shock trauma center. We now have the new addition. It's now about 400,000 square feet. It is dedicated trauma base. This is not an emergency department. It is a trauma receiving area. There's another ED for the University of Maryland Hospital. This is an area that only does trauma. There are 24 now dedicated multi-trauma beds, and all of that building is dedicated to injury. There is no mission creep here. All we do at the Shock Trauma Center is take care of terribly sick and terribly injured people. And we are designated at a level above level 1. It's the only hospital in the country. First, it's the only trauma hospital in the country. And secondly, it's the only trauma center that is designated above level 1. And that designation is set up by saying that we will always be ready and we will only take care of trauma. So we have our operating rooms are dedicated to trauma. Our recovery rooms are dedicated to trauma. The ICU beds are dedicated to trauma. The physicians are dedicated to trauma. When I'm on call for trauma, I can only cover trauma by state statute. First, I'm too busy to do anything else. But if I wanted to, it's not allowed. You must be dedicated to the Shock Trauma Center when you're on call. And we are mandated by state statute to provide services, non-clinical services like prevention, education, and research. And so it is, it's a fabulous place. It does a huge amount of work. It's the busiest trauma center in the United States. Now, when we start talking about the particular slice of injury that is interpersonal violence, there is a demographic, and this is some data that I pulled from a paper we wrote many, many years ago about on our violence prevention program. And the demographic of people that present in violence are largely men. Many of them are uninsured. Many of them are did not go above high school for their education. These are the patients that are most at risk for interpersonal violence and or ballistic injury, gunshot wounds. Now, we have had a long history of using public health solutions to solve public health problems. I may be the only person in the room old enough to remember cars without seatbelts. And, you know, when I was a kid, there was a public service campaign, right? Buckle up for safety, buckle up. That saved more lives. That stupid little song saved more lives than many, many other things because it got people to use restraints. When I was a kid, I distinctly remember being at family parties, and believe it or not, people saying to somebody that's getting ready to leave, hey, have one for the road. That was the norm, right? There was no stigma to driving while impaired. But that's changed, right? We did it with cigarettes. Cigarette smoking used to be cool. And now it's not. And how many lives have we saved by having people stop smoking? And we've frankly converted HIV, which when I was a resident, you got HIV, you were dead in a year. And that's not true anymore. So we've made huge strides using public health solutions to treat public health problems. And when you think about the magnitude of problem that injury is, you wonder, I mean, everybody's got a ribbon. Why isn't there a trauma ribbon? Why isn't there a ribbon to promote better understanding of interpersonal violence? There should be. There's not. This is a depiction of the amount of NIH funding that exists by burden of disease. So you can see there are some diseases, they're important diseases, that get a disproportionate share of the NIH funding, like cancer. Listen, nobody's going to say we want more cancer. I get that. But look who is dead last for NIH funding. That would be injury. The NIH can't spell trauma. And when we have applied, they've said, well, that's not science. No, it's not science. This is real life healthcare, and they're not interested in funding that, and they don't. Why? Now, Freddie Gray died in 2015 on 4 South Bed 13. And as everybody knows, there was a huge uptick in both social unrest and violence. This was just one of the pictures from the streets of Baltimore. But what you may not realize is that event was so impactful from the day that happened. Violence did that. And it actually never got better. This is a graph that shows this is the number of times per month somebody showed up that needed their chest opened in the middle of the emergency department, in the trauma bay. And we used to do it about 4 times a month. In April 2015, 4 became 6, became 7.5. This is the homicide numbers from the Baltimore Sun. These are not my numbers. That's April 2015. We doubled the homicides in a month. All right? 42, 29, 45, 34. And the homicides that's just a different way of saying gunshot wounds, because that's what all of them are, and these are graphs. I was astonished in not a very good way when I realized, I think that Baltimore is the only city that at least I know of that publishes homicides in the newspaper every week. You could pick up the Baltimore Sun and follow the number of people in the city that have been victims of violence and homicide. I'm not sure what that says, but I don't think it says anything very good. Now, if we reference us to other cities, as the chairman was referring to, these are just rough numbers from the last couple of years. If your Philly, you have 500 homicides on a population base of 1.6 million. I guess that's about one for every 3,000 people. In Chicago, it's 800 homicides on 2.7 million people. And in Baltimore, it was 360 homicides on a population base of 575,000 per capita, making Baltimore 4 times more violent than Chicago. If all we wanted to do was be as bad as Chicago, we would have to get down to 160. So is 250 better than 350? Hell yes, it is. Is 250 time to celebrate? I'm going to tell you, I think we're a long ways away from that. And we hope that a year from now we can say we did it again, but we have to wait and see if 2023 was a blip or 2023 is the start of a sustained change. The beginning of 2024 hasn't been so good, so we'll see. I hope so. And all of this led me to write this piece for the Washington Post. How many more parents do I have to tell that their children are dead? And in that piece, I told the story of going down to tell a mom that her young son was dead. And as I walked in, I said, I know her. And I walked over and she grabbed my hand and pulled me down to sit next to her and said, "Thank God it's you." And I said, "Okay." And she said, "You don't remember, but you told me a year ago that my son was dead. And I know you're not going to come tell me that my only other son is dead." And then I did. Now, the truth of the matter is, again, as the chairman was alluding to, we're really pretty good at this. And there have been huge advances in the care of ballistic injury that we have made over the course of the last 15 or 20 years. We transfuse people differently. We use different kinds of catheters to do this. And this has really been accomplished in a bidirectional conversation with the military. We taught the military deployed, they taught us, we taught the military, and we kind of go round and round. We're all a lot smarter than we were in the 1990s or the early 2000s. That's good for the troops. It's good for everybody. This is just a graph that shows you that the more plasma you use for every unit of blood, if you give people a unit of plasma for every unit of blood, we learned this in Iraq, the mortality is staggeringly better, 3 times better than if you don't do that. This is it's just a balloon, right? Before, what we would do is we would have to open your chest and put a clamp on the big blood vessel in your chest in order to control hemorrhage. Now what we do is we do a puncture in your groin, put a sheath in, and then thread that balloon up and blow the balloon up on the inside. Pretty slick. Much better than me opening your chest. This saves lives. Now, when we look at violence in our shop, there has been an increase from 48 to 60% of interpersonal violence that are gunshot wounds. The number is about 1,000. That's been fairly steady. The number of ballistic injuries is now 600. Kind of 1.5 or 2 every day. This year, it seems like, or last year, it seems like what they did is they came in clusters. So we wouldn't see a gunshot wound for a couple of days, and then we see 5 in one day. Often temporally related. And if you look over the course of the last several years, we have doubled the number of kids under the age of 20 that have come and shot. It is now a disease, not completely, but adolescents represent a big part of who it is we care for that have been shot. There are, a number of innovative ways to care for injury. This balloon looks just a balloon in a catheter. We have inserted that through the middle of somebody's liver and blown it up to stop the bleeding. The alternative is I take the whole right lobe of the liver out. I'm going with the balloon. That picture, believe it or not, that's the biggest vein in your body with a big hole in it. And we've put a balloon in on the inside to stop the bleeding. That patient is still very much alive. And that's me getting control with some loops and then a clamp. We have published the only series in the literature of the use of this balloon with 80% survival. Not so bad. We're better than we used to be. And this is the young man. I will give you several vignettes. This is the young man I talked about at the press conference. He came in with a gunshot wound, and that's a CT scan. Those big white, let me see, do I have them? Yes, maybe. That's his heart. Those are the blood vessels coming out of his heart. There's the injury, and it has injured the blood vessels immediately adjacent to his heart. He arrived without, baloney. He arrived without any blood pressure. We got him out of the bay, through the scanner, in the operating room. I took his entire right lung out. It's a big operation. We cannulated him in the operating room and put him on a form of cardiopulmonary bypass. And we did that in about 90 minutes. That's shock trauma speed. Now, would he die everywhere else? He would die almost everywhere else. This kid was in the hospital for 2 months. He was on the bypass circuit for about a week and a half, if I remember correctly. And I estimated his hospital bill at $500,000. It's a lot of money. He's alive. And he wouldn't be alive almost anywhere else. I'm all for that people living that would die everywhere else. This is a fellow that came in with a gunshot wound. You can see his right chest is full of blood. I got him up. He also had no discernible blood pressure. He had a huge injury to his liver right next to that big blood vessel. Same thing. And I'm struggling, and in walks one of my senior partners, Deb Stein, as I'm trying to get this guy to stop bleeding. He says, well, you want me to put him on bypass? So, Jesus, why didn't I think of that? I was so coned in on trying to do this. Now, how many places have 60 years or 70 years of trauma experience in an operating room at 6 a.m.? That's one place. Deb cannulated him while I kept going. He did well, and I still see him back in follow-up. That is the level of care that we are able to provide. Now, there is a cost to all of this, and it is not just the in-hospital cost, because the effects of injury don't stop when somebody leaves the hospital. And particularly for ballistic injury, there are mental health and rehabilitation needs that go on for years, sometimes their entire life. I recently had a guy that came in with a terrible gunshot wound to his pelvis. It took me a year and a half to get his intestine reconnected and everything going in the right direction. And he came back and I said, boy, this is great. And he said, Dr. Scalia, it's not great. I said, he showed me his arm. He didn't even have a fracture, but he had nerve injury from the concomitant gunshot wound to the arm. He said, I make my living picking heavy things up. So it's all I know how to do. I'm really good at picking heavy things up, but that's all I know to do. I can't work anymore. So this guy, who was a great save, is disabled. Now, eventually, I'm happy to say I got him a job working for the hospital, but for 3 or 4 years, he was unemployable. And I think it is important to remember that the issues of injury, particularly gunshot wound injuries, particularly because those are often young people, these issues go on for months, years, or forever. Now, there is a psychological and physical cost to these gunshot wounds. We talk about the costs to the patient, which are substantial, but I have to tell you that there's a huge wear and tear cost on the people taking care of those people. It is particularly because those injuries are all preventable. So we're beaten down after years and years and years of doing this every day. And when I have to go tell a mom or a family that their kid's not coming home, I could tell you the number of steps I have to take to get to the waiting room. The number of times and it's the same thing. Please don't tell me. Please, you're not going to tell me. It's really demoralizing. And every time I do that, I lose a little piece of me. And my staff loses a little piece of them. And there's a little bit of me left, but there's not as much left as there used to be. And what we need to do is both mitigate the consequences of this and prevent it. And so we have just started at the University of Maryland, the Center for Violence Prevention, with a very generous gift from Betsy Sherman and her foundation. And so that is up and going. And if you just look around the trauma centers in the state of Maryland, there are many of trauma intervention or trauma prevention programs, including our violence intervention program, which was the first hospital-based violence intervention program in the United States. At least that's what I have been told. And so as we think about organizing this, and the governor wants to set up an office of violence prevention, gun violence prevention, I would suggest to you that linking resources and combining all of the existing programs in a way that is synergistic would really be a good idea. This is not me saying I want to run this. This is me saying that I think that we ought to be able to get economy of scale from some very good programs that already exist. And we have an office, we have MIMS. Where it sits is immaterial to me, but I think it's an opportunity to do this. This is my office. This is a corner of my office. And that picture has hung there for 5 years. It was shot by a guy named Koos Hamburger. And there we are doing CPR on a young man that came in shot. And it has become clear to me that he is not going to survive. And all I can do is put my head in my hands. And the caption on that is physician contemplation at the bedside, once focused solely on the diagnosis and treatment, now succumbs to the reviews of the social conditions which prompted the admission in a city where daily violence infuses the streets with blood. Even in the best trauma care is too small a bandage for the gaping wounds of a gun-ridden society. So I ask you one more time, how many more parents do I have to tell that their children are dead? I can't tell you how supportive I am of the work that the legislature is doing to try to help us, all of us, both deal with and prevent violent injury. And I very much appreciate your invitation, Mr. Chairman. Thank you.
Excellent. Thank you very much, Doctor. And I think I speak for the entire committee and anyone who has any inclination as to what you do on a daily basis, that we're all very thankful that we have people like you in the state of Maryland serving us. So thank you for your service and thank you for this presentation. We get a lot of hot air in this committee, and I'll tell you, this is one of the more instructive and I think effective presentations we've ever seen. And so thank you very much. I think it'll help us as we move forward. So as we said, we'll hold off to questions until we go until the end of our presentations today. So next, thank you again, Dr. Scalia. Next, we'll hear from Johns Hopkins University. I see we have Dr. Webster's here, but we're going to hear. Are we going to do the Zoom in presentation first? We'll be last. Oh, he'll be last. Okay, so is Dr. Webster going to go first? Oh, excellent. That's fine. But yeah, absolutely. So next we'll have Daniel Webster, who's the director for the Center for Gun Policy and Research at Johns Hopkins University. Dr. Webster, good to see you again. Welcome and thank you for your time today. Thank you for joining us. If you could stand at the podium, that'd be great.
Get this.
Okay. Hello, Daniel Webster, I'm professor at Johns Hopkins. Been working on the issue of gun violence for over 30 years. Thank you for inviting me to speak to you today. You know, I think the reductions in homicides that we've seen in Baltimore City and Baltimore County are certainly to be celebrated, but still we have not seen those decreases statewide. And most troubling, and I think of greatest concern for, certainly for legislators, is the increase in gun violence involving teens in particular. Why are we seeing these trends? I'm going to offer my own opinion based upon what admittedly is patchwork data and talking to people close to the problem, like violence interrupters, for example. I'm going to sort of end my comments coming back to this patchwork data part, because I think that's actually maybe where the solution ultimately comes from. So let's talk about the availability of guns and how that has changed in recent years. If you simply compare 2023 to 2019, the last year prior to the pandemic, gun sales are at least or twice as high. We've also seen a very large increase in applications for concealed carry permits after the Supreme Court decision in 2022. Why is this relevant to youth? Teens can't legally purchase guns. Well, one reason is that, well, there are actually two reasons. One is that teens often get guns through theft, particularly thefts of from motor vehicles. What we've learned studying the deregulation of concealed carry laws across the country, and other studies have found, is that when you make it easier for civilians to carry concealed weapons, it's not necessarily the permit holders themselves that are causing a lot of harm, but many of them leave guns in their motor vehicles, and those guns are recovered. So one study from Stanford found that an important connecting piece between the rise in gun violence and deregulation of concealed carry is a 35% increase in theft of guns from motor vehicles. So that's one way in which guns are becoming more available, and there's more supply. Another, of course, is something that you've already considered, which is the emergence of ghost guns and privately made unserialized guns. The demand for guns among teens is also increased. It's a thing that sort of feeds on itself. Gun violence goes up, there's more demand, they feel more at risk, and more people want guns. So there's more supply and more demand. What suppresses that demand? Well, partly is likelihood that you're going to get caught carrying a gun. And I think law enforcement capacity to enforce those laws are not near what it used to be. So I know this legislative body most, commonly thinks about simply the penalty side of this, but what research tells us is that it's more the likelihood that you will get caught than the severity of those consequences. And that's one of the things that we're struggling with. The other thing that is an important driver of youth-related gun violence is social media and exchanges in social media, a lot of prompting, threats, people trying to get attention using guns and violence. None of our programs and policies are really adequately oriented to address this emerging and growing problem. So if we want to address youth gun violence, we are going to have to actually develop interventions, policies, and programs that address that component, because currently those programs and policies miss this important driver. I'm going to come back to the data part here. I just shared with you, again, bits and pieces of different data that I've been able to accumulate, knowledge connecting to people close to the problem. But really what I want to promote is something that our Center for Gun Violence Solution is really promoting right now, which is the development of local violence reduction councils. What are these things? They come from a model some may know of, homicide or shooting review commissions, but it's a very systematic way in which law enforcement, other government agencies, social service providers, outreach workers, violence interrupters come together. They are all looking at the data together on a regular basis. They're developing solutions that are based upon those data. And there's a system for accountability for implementing those evidence-informed strategies. So there are some localities that have nice little dashboards that has some very basic information, and that's great. They're really only sort of at the superficial level. They don't really tell you what's underneath that, what is driving, what is the spark that led to that shooting, and what's the longer course development of how that teen got in that situation to begin with. I led homicide review in Baltimore in 2015. It was very illuminating. Just as an example, one of the things that we learned reviewing, I believe, approximately 70 individuals who were either victims or offenders in those cases, one had graduated high school. One. All had dropped out, very commonly were at least one or sometimes two grades behind when they did drop out. A lot of unmet needs, both within the schools and with the families of those young people. So I'm just giving you an example of the things that you learn when you look deep at the data and then you start to develop what are the solutions from it. So the degree to which, this legislative body can encourage, promote these kind of deep level examination of data and collaborative problem solving initiatives, I think we'll gain much more ground and understanding of what it is that's driving the problem. So if I or anybody else comes before you and you want to know what in the heck is going on, why are we seeing this violence, to actually have facts that are validated and seen across many different spectrum, whether you're law enforcement or you're working as an outreach worker, what are you seeing at the problem? Those are my comments today.
Excellent. Thank you very much. And thank you for your work. I follow your work very closely, and definitely a value add for us here, for the folks who follow it, and for the state of Maryland. So thank you. We'll continue on with the panel. Who would you like to go next? Oh, excellent.
Good afternoon. My name is Nathan Irvin. I'm on faculty in the Department of Emergency Medicine at Johns Hopkins. I'm also the medical director for the Break the Cycle Violence Intervention Program. And I'm here with the rest of our team to discuss with you all kind of the work that we do. Violence prevention to me is something that's really personal. I grew up in Southern California. I grew up in a community that was ridden with gang violence, and I watched many of my friends join gangs. I watched many of my friends become shooters, and unfortunately, I had some of my friends become victims as well. And it's always something that stuck with me. And I recognize that these were youth with tremendous talent and tremendous opportunity to do something different had they had different circumstances and positive influences in their lives. And I embarked upon a career in emergency medicine to try to be one of those people who was a positive force for folks' lives. The ethos of emergency medicine is anyone, anytime, and I think we try to live up to that. We take a lot of pride in being able to be there for people in the darkest days of their lives, the darkest events that happen to them. And over the course of my almost 20 years as an emergency physician, I've seen thousands and thousands of patients. I've seen hundreds of people die. I've borne witness to a lot of the tremendous evils that happen in this world. And I could tell you that there's nothing that bothers me more than seeing our young people who come in before they have an opportunity to really live out their life, come in as victims of violence, many of which will be fatal. On a day-to-day basis, I'm tasked with going and telling a patient that they may not walk again because of the gunshot wound that they sustained. I'm charged with going and breaking bad news to a family whose life is irrevocably wrecked after learning that their loved one has died and will no longer be there for Christmas or for their birthday or whatever that next occasion is. And it's traumatizing. It's traumatizing for those families, but it's traumatizing for us as providers who are tasked with trying to do the sort of heavy lifting for that. Additionally, I think I've worked in a lot of different environments, and many of the places I've worked have not had the ability to have programming that can be effective in helping to support the needs of this population. And so there's an added moral injury that happens when you go and you take care of somebody and you're able to save them. And then you hand them a list of resources and essentially put a Band-Aid on them, recognizing that there are evidence-based practices that exist and that could be stood up had that hospital had the resources to do so. So fortunately, I'm part of the Johns Hopkins Violence Intervention Program, which is called Break the Cycle. We are a hospital-based violence intervention program, and these are programs that work on the sort of idea that violence is preventable, and that in order to affect change, we need to be able to meet these youth where they are, during what we call the teachable moments. Those are times when, because of your injury, because of what happened to you, you're introspective and open and willing to change, and really seizing on those opportunities in order to help advance in order to engage that individual and to help them to move their life more productively. This is not moving. Yeah, neither of them are working. No problem.
If we. There you go.
All right. All right. So we are an HVIP, hospital-based violence vigil programs. Like I said, work with the notion that violence is preventable and that we can do work within the hospital context to be able to help move people's lives productively forward. Our program is called Break the Cycle. We've been funded through the Department of Justice. We've been funded through ARPA funding, and we're currently being funded through the Johns Hopkins Hospital. And we are a program that engages victims of violence who have been shot or stabbed or brutally assaulted. And we work with the goal of trying to prevent recurrent injury and to support healing and recovery holistically for the individuals that are involved in our program. We are a multidisciplinary initiative, recognizing that violence has lots of different things that are drivers of it and requires a holistic approach and a holistic lens to support our victims and subsequent sort of clients that were part of our program. We have a team that's made up of case management individuals from our social work department, our violence intervention specialists, as well as physicians from the emergency department, as well as the Department of Trauma. And I think really the heart and soul of our program are in our credible messengers, our violence intervention specialists who use their lived experiences and voices in order to be able to really champion and connect with our youth in a different way than other folks in the healthcare system are able to, and really help to move folks' lives forward. So I'm going to pass it off to Diane Lepley, who's going to tell you a little bit more about what our program does and some of the outcomes of our program.
Good afternoon, Chairman Smith, esteemed committee members. My name is Diane Lepley. I'm a nurse at Johns Hopkins Hospital, and I'm the Executive Director of Care Coordination Programs. And I'm here today to tell you about our Hospital Violence Intervention Program, the eligibility for the program, the impact that it makes, but probably most importantly, some stories from the field, how it really works and the impact that it can make. Our eligibility criteria is a patient who comes in with either a gunshot wound and stabbing. They are residents of Baltimore City, and they're between the ages of 15 and 35. We have a holistic approach. We really take kind of a public health approach to care, where we are looking at establishing trust during that teachable moment with our specialists, and then build upon that. We are working to try to address life coaching skills, provide social access to violence intervention programs in the community, and then also address social determinant needs that we find are lacking in many of the patients that we're treating. So what is the impact? How are we doing? We are here today to tell you that we have promising news of both prevention and response for our program. So for instance, in FY23, there are 490 emergency department visits due to violent assault, gunshot wound, stabbing at Johns Hopkins Hospital. 50% of those encounters were localized to just 5 Baltimore City zip codes. Again, we are serving residents who are between the age of 15 and 35. 20% of those program participants are under the age of 18, and the average age is 24. Some of the promising results year to date: of 130 program participants, 3% returned to a Maryland hospital with a new firearm injury within 12 months of follow-up. That is significantly lower of what you would see in published literature that can be as high as 45%. Even our prior work in this area, where re-injury rates are as high as 16%, we've had promising results year to date on our work. How does our work impact our recipients? We do it in 3 ways. Number one, it's life coaching. With conflict mediation skills and de-escalation skills that we try to transfer to victims. Secondly, it's really about linking them to community-based programs for longitudinal follow-up and providing extensive case management. We do also a significant amount of dispensing of social determinant support with temporary housing, safe housing, transportation, and probably most importantly, also linkages to behavioral health and addiction services that many of our victims need. Next, I would love to turn over the mic to 2 of our superstars, our violence intervention specialists, to tell you a little bit about the day in the life of their work. And then lastly, what are some recommendations of how we might be able to scale, spread, magnify the promising work that we have with some concrete recommendations.
Good afternoon, everyone. My name is Eson Cornish, and I've been a violence intervention specialist at Johns Hopkins Hospital since September 2022. Before I got into this line of work, I worked in surgery for 4 years. But nonetheless, what led me into this field of work is a combination of things. I'll share just a few with y'all. My upbringing, my lived experience, and also having a burning desire to see others who had similar experiences or similar backgrounds overcome the same obstacles and barriers that we are confronted with in the environments that we come from. I myself particularly, and the majority of the population that we service each and every day. The things that hinder us and from having a legit, productive, and successful life. That's why I'm here, and that's why I came into this line of work. BCHVIP, Violence Intervention Program, it's not your typical functioning program. We take a trauma-informed and relationship-driven approach into this line of work. The reason why we use this approach, because everything that we do is based on trust. Trust has to be established, and it's the underlining of everything else that we do. I want to highlight a couple cases just to give y'all some examples, some real life examples of the work we're doing. I want to kind of draw a picture of a beautiful house. When you see a beautiful house, you look at it and you may even desire it. Or as you go inside that house, you see there's holes in the wall and there's cracks. And you realize that there's still work that needs to be done in order to present this beautiful house to the buyer as something that they would want to invest in. Same thing with BCHVIP, Hospital Violence Intervention Program. It's a very beautiful thing that we have going on, but they're all holes, they're all gaps, they're all things that we need to fix. I want to use the name John Doe. due to policy. But we had a young man who I am working with to this day. He was hit or shot in a multiple gun shooting. He was the sole survivor. Obviously, and very unfortunately, his partner or acquaintance, he did not make it. So I met this young man on the bed at the bedside, introduced myself, let him know who I am, where I come from, where I'm at presently, and why I am there. And me and the young man, we connected. And as he began to get himself together physically and prepared to be discharged from the hospital, as we do, we also follow our clients and patients once they go back out into society. We just don't leave them once they leave the hospital. We case manage up to 12 to 18 months if necessary. So I followed this young man, and the engagement was great. I perceived this young man to be kind of beyond his years, and he was just a little past his teenage years. And we began to build, you know, and touched on some things, and I was able to engage him to the extent that I was able to get him to disclose what he wanted to do with his life to make things better, to get things better, to enter on another trajectory. And he shared with me that he desired, you know, to go to vocational school, to take up a trade. You know, once upon a time, you know, families, Black families particularly, they used to take care of their families through accumulating a trade or something of that sort. You know, not so much going to school or going to college, but a lot of good things was done, you know, just by having a trade. So make a long story short, he has a certification, present tense, in HVAC, and he is also seeking to transition into his career field. But once again, there are holes in the wall. This young man, he's from the city of Baltimore, and he desires to get out of the city of Baltimore. It is to my understanding that the perpetrators that victimize him is still out there. Yet he still navigated through all that and went to school and accomplished his certification. But we struggle with him or getting him outside of the region so he could start a new life where he don't have to worry about the past any longer, things that traumatized him already. We also had another young lady I want to refer to. She was shot on her way to work in the heart of East Baltimore. And met her in the bedside, connected with her, and she was receptive of the program and things that we had to offer. So we wanted her to get out of her region as soon as possible. But the resource didn't respond quick enough. But fortunately, she had something else going on in the time being where she was able to move right away. We came in and assisted her with rent, security deposit, BGE, different bills of that sort. And the agreement that we had with her, once her new lease in the new place was up, we would help her transition into a better environment. Here's a young lady, she's married, she has 3 kids, 3 young men, who has to grow up in these negative environments that a lot of times contributes to people end up becoming criminals or lawbreakers, you know? So that's the picture I want to draw to y'all. We have other referrals we can mention. Got a young kid, he got shot 2 times in less than a week. The second time he got shot with his mother. We got him out of town right away. We have another referrals where we got a kid, his father, he has to look at his son being a quadriplegic now. You know, we provided a means to get his father and his family in a safer location, you know, so he can begin this new life, unfortunately, that he has to live. So once again, what we have going on is a very beautiful thing. It's a very optimistic thing, and it is bringing change. But like that beautiful house, when you observe it from the outside, yet when you look in, you see the holes in the cracks and you realize it still need work within. And that's why we're here today. And I hope that, you know, we can gather and fix some of these holes in the wall. Thank you for your time.
Good afternoon, everyone. Senator Smith. My name is Nadia Abdullah. I've been employed at Johns Hopkins Hospital for the past 22 years, 15 years in the admissions registration department, working primarily in the adult emergency department. 6 years in the Department of Psychiatry, again, working primarily in the Department of Emergency Medicine. The past 14 months, I've been working for the Care Coordination Department. My role there is a violence intervention specialist. And as a violence intervention specialist, my role is that I engage patients at bedsides that come into our hospital as a result of GSW, gunshot wounds, and stab wounds. And given the fact that I understand that being shot or stabbed is a traumatic experience, my engagement with the patients is from an informed trauma approach. And I do have 2 case studies from my caseload, briefly, that I would like to present. Jason is a 20-year-old male patient who arrived in our emergency department as adult trauma resulting from an intentional gunshot wound. The circumstances involved, after eating crabs and drinking beer with friends one summer afternoon, he was walking to his car when he was approached by an unknown male. The suspect displayed a handgun and attempted to rob him. After the victim said he did not have any money, the suspect attempted to go into his pocket and a struggle ensued. It was at that time that the suspect shot the victim in his right ear with the bullet exiting his left eye. The victim is a high school graduate and was employed full-time as a driver for a major distribution company. He wasn't affiliated with a gang. He has never been involved in the criminal justice system, and he's not a violent individual. He lost his job and became depressed and spent most of his time at home, often being afraid to go outside of the house. His ultimate goal is to regain his full vision in his left eye and return to work. Through phone conversations and office visits, we have developed a respectable relationship. He has followed through on all of his appointments, and he's working a part-time job. Unfortunately, a major barrier to his recovery is when he felt he needed therapy because of nightmares and flashbacks. He was unable to schedule an appointment to see a therapist because there was no open slots available when he called, highlighting the need for more programs and resources for mental health for our youth population. The second case, Malik is a 25-year-old male patient that arrived in the emergency department as adult trauma for a gunshot wound to the back. He was born and raised in Baltimore City. He is unemployed. He denied being associated with the gang, but admits that some of his associates from the neighborhood are involved in drugs and gang activity. As a result, they feel it necessary to protect the neighborhood from outsiders. When the outsiders came into the neighborhood, words were exchanged and a fight broke out. Shots rang out, and as he was running away, he discovered he had been shot. The victim lives with his mother, but generally stays with his girlfriend and their 2-year-old daughter. It's difficult to maintain communication with him because his cell phone is often turned off. He's looking for employment, and together we are actively working towards that end. Because of our relationship and many teachable moments, he has agreed not to retaliate. He said he was going to let it go. Again, showing that engagement at the right time can prevent and break the cycle of violence. We understand that partnership is the most effective form of leadership in reducing gun violence. Thank you.
So where do we get better? How can we sharpen our effectiveness and the impact that we can make in this world? Expand and invest in hospital violence intervention programs across all Maryland trauma centers. Currently, there are 8 in operation, with University of Maryland being the longest. Collect and analyze longitudinal data on gun violence and interventions. so that we can understand where we need to get better and the impact that we're making. Expand access to mental health services and addiction medicine services for victims and families. We know that PTSD is very, very prevalent, up to 50% in our population. Work cooperatively to develop and support proactive, this is very important for prevention, proactive peer and adult mentorship programs in the community. And lastly, create access to temporary housing and transportation to many of our victims of crime. Thank you for your time and attention this afternoon.
Excellent. Thank you very much. We're going to round out the panel now with Dr. Sakran, who's going to join us via Zoom. We see you there, and I think your mute button's off. Good afternoon. Welcome. Thank you for joining us.
Good afternoon, Chairman Smith. Are you guys able to hear me okay?
We can, yes.
Okay, perfect. Sorry, I couldn't be there in person, but thank you for accommodating me via Zoom. And I just want to say, both to you and the Vice Chair, Walt Stryker, as well as the distinguished members of the Maryland Senate Judicial Proceedings Committee, thanks for having me back. It's an important opportunity to provide testimony on youth violence that's plaguing both our state and our nation. My name is Joseph Sakran, and I come before you today not just as the chair of the Brady Board, but as a survivor of gun violence. At the age of 17, I was nearly killed after being shot in the throat with a .38 caliber bullet. And that moment really changed the trajectory of my life and inspired me to go into medicine and to become a trauma surgeon, where I currently spend most of my time dealing with the daily toll of gun violence at the Johns Hopkins Hospital. In America, gun violence is the #1 cause of death in children and adolescents. It's not car crashes, it's not poisonings, it's not cancer, it's guns. And by the way, this holds true for the state of Maryland, where an average of 67 children and teens die by guns every year, of which 17% of these deaths are suicide and 82% are homicides. Nationwide, when we look at this problem, we have nearly 4.6 million minors that live in homes with unsecured firearms. And when you look at unintentional shootings, school shootings, and suicides by minors, we know that 70 to 90% of those firearms are acquired from the home or from homes of friends or relatives. And this is one of the reasons I was so proud to support Senator Smith's bill around firearm safety storage, also known as Jalen's Law, and was glad to see that Governor Moore signed it last year. Now, while that was a step in the right direction, it's important to remember that there is no one solution in tackling this public health problem. As we've heard from my colleagues today, this issue requires us to implement a multifaceted approach that cuts across sectors in order to really break down the silos that exist in our cities and across our state. And while I'm grateful to be here with all of you discussing what I think is the most important public health crisis of our time, I'm also incredibly heartbroken and disappointed at having to watch the daily carnage that's destroying families and decimating communities across the state and beyond. As a trauma surgeon, we come face to face with the horrific reality of gun violence every day. We have to operate on children who are barely clinging on to life because of guns not safely stored. We've had to deliver babies from dead mothers who were gunned down while sitting in their own car. And we have to care for high school students that are bleeding to death with pulverized bone and mangled extremities. And my personal experience as both a survivor and trauma surgeon has allowed me to see firsthand that the best medical treatment is prevention. Part of the problem is that far too many Marylanders, the horror feels hypothetical. Many of you watching this can often never even imagine that this is a possibility. And as you go home tonight and are surrounded by your loving families in the safety of your home, I would implore you to remember that these threats are anything but hypothetical. I've seen this firsthand in my own life, and I have to see it all too often in the work that we do. While many are shielded from the realities of this horror, I think the truth of this is important. After all, we have parents who not only experience the anguish of losing a child, but must submit a DNA sample to identify their kid because the damage is so severe, their body is unrecognizable. And while we're not here today to testify about a specific bill, but to talk about this ongoing public health crisis, I'd like to underscore the importance of needing to have a coordinated effort across the state of Maryland. Governor Moore announced interest in opening a statewide center focused on gun violence prevention. I think this is a critical step to ensure that we have the type of statewide infrastructure in place to coordinate efforts across Maryland, while at the same time allowing us to partner with the federal government agencies, including the newly created office in the White House of Gun Violence Prevention. Being able to tap into those federal dollars and then getting them to where they need to go will be important. And this is something that the legislature has the ability to promptly act on and make happen. Thank you so much for the opportunity to be here with you all.
Thank you very much, Dr. Saccharin. Sorry you couldn't be here in person, but we're delighted that you could join us and provide us with that testimony. So thank you for taking the time. Are you going to stick around with us for questions, or?
Yeah, I have to leave at 2:30, but I'll stick around as long as I can. Thank you.
Okay, excellent. Well, thanks. So we're going to, if you have questions for Dr. Saccharin, if not, we have one more presentation, then we'll move on. All right, so that'll conclude this segment of the presentation. Thank you all very much. I know we're going to come back for Q&A, but thank you all for taking the time. It was fantastic. Thank you. Especially the concrete recommendations part. I like that. It was good stuff. Now we'll hear from Center for Hope. Or do we have anyone else from Johns Hopkins? That was it, right? Excellent. Thank you. Now we'll hear from Center from Hope, Freedom Jones. Ms. Jones, welcome.
So I move it forward, so you can just scroll down. Or you can move that. Hello, again, my name is Freedom Jones. I'm the Director of Community Violence Intervention Programs for the Center for Hope, which is a LifeBridge program. Before I start the presentation, I want to thank you all. I want to thank you for your commitment to mitigating violence in Baltimore. I want to thank you for what you've done already and what you're going to do. Because one of the things that I know, I have had a privilege of being a part of the Chicago Violence Leadership Academy, the first of its kind in the country. I'm convening with 21 cities, and we're discussing violence from head to toe and coming up with solutions, recommendations around how to solve this crisis. And I say crisis because this is a public health approach. And when COVID hit, we recognized that we all had to get together and solve the problem. Well, violence is an epidemic, as you know. So again, thank you for all that you're doing. You know, I'm really grateful because we're presenting to the White House in February, and it's going to be an amazing feat because we're creating history in a movement that has become a coordinated effort. You know, and coordination is one of the things that has been lacking in this field. So, Center for Hope, I heard, you know, we've been talking about the problems. You've been hearing the stories. But one of the things that I'm extremely proud of is that we have developed in a small circle in Baltimore one of the solutions. And LifeBridge Center for Hope, they have a tagline. When I started working for them, and I was like, okay, I'm working for a healthcare system. And I know the bureaucracy in a healthcare system. And I was like, can I do this? Because I come from the streets. I did this work in New York, and it almost killed me. You know, I didn't come from the I was one of the credible messengers. I got into it learning how to be credible. And when I came to Baltimore, I got on the streets here in Baltimore because I wanted to learn the culture here, the street culture, so I could be as credible. I ran the Hurricane Sandy effort in New York, but when I left there, I came here and I said, so what is my calling? My calling is to save lives and prevent violence. And I said, how do I do that? I understand politics. I understand the layers of which you make change, but I didn't understand the culture. So I took a job as a Safe Streets site director, and that was the hardest. I used to work for the federal government. I'm not going to tell you what I did, but I did some things back in the day when I graduated. And when I came here, I took that job, and it was the hardest job of my life, because I was on the streets mitigating violence with a group of men and women who were risking their lives. And so after I did that and I learned the culture, I got the privilege to work at the Center for Hope. And the Center for Hope was a part of this healthcare system. And this healthcare system was something that I didn't understand. And so they had a tagline, and the tagline was caring bravely. And so we didn't have all the Safe Streets components that we have now, but the hospital took a risk. They took a risk, and they took on a lot of community programs to begin to look at how violence affects their ER room, how violence affects the traffic that comes to the hospital. And they took an action. Excuse me, I'm fasting. This is day 17 of water, so I have to drink a little water. Excuse me. I'm doing 30 days of water because, and I'm gonna tell you why at the end of this, okay? So please forgive me, okay? So I'm on 30 days of water, this is day 17. So, trauma will hurt you if you don't take care of yourself, okay? So, the first slide that you're seeing is LifeBridge's consortium of services that they're providing and we're using to really begin to mitigate violence. So you see there's community programs, there's healthcare systems, there's intervention programs, and there's preventive programs. And so I'm really grateful because what we recognize in this field, violence cannot be addressed with one, it has to be a coordinated, robust way to identify and to mitigate violence. So LifeBridge has a consortium of programs. They can service the ages from 0 to 100. And that kind of brings me to the term ecosystem. And I know some of you have heard the term ecosystem. The mayor in Baltimore has had a huge violence intervention plan, and the term ecosystem is used all the time. Well, an ecosystem is a reflective of collaboration, a coordinated effort of services to be able to address violence from several different angles. You've got community outreach, you've got mediation and intervention, you've got hospital-based programs, you've got life coaching, and you've got victim services. The Center for Hope has its mini ecosystem. So we are providing all of those services in-house. This is our public health ecosystem. And you can do this. Our hospital responder programs, we deal with domestic violence, human trafficking, sexual abuse, all of the trauma-informed programs along with gunshot victims that come in through the hospital. We meet at bedside and provide case management for short and long-term services. We have mental health services. We have elder abuse services. We have education and prevention services. We have mental health services. We have a coordinated effort to really be able to address someone who comes into the hospital. They can be connected to these services in-house. And so we have a mini ecosystem that is wrapping ourselves around folks who have been victims of trauma. The programs and ecosystem that we do have, definitely, as you know, are under the umbrella of a public health approach. And a public health approach is a coordinated effort. It is about making community partners. It's about clinical services. It's about youth prevention programs. It's about hospital teams. And so one of the beautiful things about working for a healthcare system that I'm involved with is that we've developed a marketing strategy, you know, like the smoking cessation strategy. Unless you address violence in several different layers, you're not going to really be able to serve this work with intention. And this work has to be served with intention. One of the things I've learned is that we're not going to have all the answers. You're doing great work, but you don't have all the answers. You know, as a result of this Leadership Academy, I can call on experts. I had to call on an expert this morning because I was dealing with an issue. I called on Erica Ford from New York. I said, Erica, how do I deal with this? And so she helped me strategize around my public health approach, how to strategize around the bad press that we receive. So again, this public health approach that we're doing at LifeBridge Center for Hope is a coordinated effort of all these services. Here's some of the statistical information. The numbers: 6,000 survivors of abuse and homicide, 1,300 children served. I'm not going to go through the numbers because you can see them, but because of our coordinated effort, because of our mini ecosystem, you can see that we are reaching a broad scope of individuals who are affected by gun violence. We're able to reach those who witness gun violence. You know, I was in a I took a lift. I'm sorry, I'm fasting. So I had to park in a garage that was pretty far away and I could not walk. So I took a lift. And, you know, I always talk about violence. And the person who was the driver said, you know, I was almost killed in 2018 here in Annapolis. The people in my lift were shot in the back. I was supposed to be dead. So he was traumatized. He was not directly impacted by a bullet, but he has been traumatized. Like many of us have been traumatized, like the workers who are working in this field have been traumatized. One of the things that we understand at the Center for Hope is that we have done the folks who are doing this work a disservice. We have not supported them the way we need to support them. So we're building out this new program at the Center for Hope called the Executive Presence Institute. It's a new type of college for professionals because this field, you know, when I was speaking to Erica this morning, she said, you know, Freedom, this is not a profession. I say it's a profession because I want people to understand that the men and women who are risking their lives deserve to be treated like professionals. This is an industry, like the construction industry, like the music industry. We are building an industry together. And so one of the things that I wanted to talk about was the profession, the industry. Well, the men and women who do this work are credible messengers. They come from the work. So they start a job in a nonprofit, maybe some of them the first job they've ever had, and they've never had an understanding of what field they've entered. They have never dealt with the trauma that they have experienced. And we expect them to go day in and day out doing this work. So we're building a new type of college so that eventually the men and women could run this college. And it is a career path to success. It's going to teach them how to become successful in a nonprofit. It's going to teach them how to do this work intentionally on the street. How do you become the best responder? Because we have never set a report card. We've never developed their skill set. And then we're going to teach them and help them deal with the trauma that they brought in the door while they were working. So we're going to get them a counselor. We're going to have them do peer-to-peer support around their trauma because their families are feeling the trauma. And then we're going to teach the institution. Let me tell you, Center for Hope, LifeBridge, had no idea what they were getting into. They cared bravely. They didn't know what this work could potentially cost them, what this work required. And so this institute will teach the CBO, the profession, how to do this work. It will teach them and work with them to understand so that the profession does not change to fit the institution. And so we're building that out. So we're really happy about doing that. We're launching that in February. I'll keep you all posted. So some of the successes that have happened at the hospital. So, You know, this is a coordinated effort from the ground level to the folks that come and are met at bedside. We have seen a 28 reduction in gunshot victims come through the hospital. That is a huge success. I just talked to the director of trauma at the hospital. We're now looking at higher numbers. Why did that number happen? It happened because the folks on the street connected to the folks inside the hospital. The folks on the street connected to the community members. The folks on the street connected with the clergy. The folks on the street connected with the mayor's office of neighborhood safety and engagement. So it was a coordinated effort. So, recommendations. As you all know, reform and improvements for victim compensation. We don't take care of our victims enough. We don't take care of the folks in the families who lost a loved one. So we need to think about our victim compensation. And I can't tell you, we can fight this battle from an intervention, prevention, and crisis management place, but until we understand the number of guns and things that are brought into the streets and address that issue, we might be losing the battle. So educate, divert gun violence, implement conflict resolution programs, and you can read all of this, excuse me. Let me slow down, I'm from New York and I can talk fast. Our approach to gun violence as a public health crisis. We're in an epidemic. You know, we really have to understand that this is a crisis. And we had a reduction this year in Baltimore. Thank goodness that we're doing something right. But we don't want that to be a fluke. We want that to be a consistent downward spiral, because we're not celebrating. The mayor did a press conference, we were all there. He said, this is not a celebration, this is just the beginning. So we have to recognize that and understand that and not forget that this is a crisis. And financial and program for support for the CVI professions. I, as a result of the CVI leadership, I have been looking at national standards and what it costs to really save or to help or to address a high-risk individual. It's roughly $25,000 to $35,000 per participant. And I'll share that there's a formula, because we're creating national formulas. There's statistical information that tell us what is required for high-risk reduction. We are only scratching the surface in Baltimore. We have not fully put the dollars into what is necessary to really win, or not win, to address the health crisis. And so that's what I have to say for you today. Thank you so much for your time, and I'm looking forward to questions.
Excellent. Thank you very much, Ms. Jones. I really enjoyed the presentation, and thank you to all the panelists today. I'll tell you, I think this is one of the better briefings we've had. It's instructive. You provided vignettes and on the ground experiences, real number information, data, but also you didn't just admire the problem. You offered concrete solutions that we can move forward with in the legislature, and also a lot to think about. So I just want to say thank you to all of you. You all have very important work to do, and you spent some time with us. This information is not only for the committee members, but for the general public. So, all the information that was provided, the slides will be captured on our website and accessible to any Marylander that knows to go to our website and access that information. So it's a real public service that you provided today. So I want to say thank you. We'll now switch to the committee for questions of any panelists. And I see Senator Muse is up first. So Senator, you're up.
Mr. Chairman, and let me join with my chairman in saying, again, we are grateful, we're thankful that you came to share with us. We've learned a lot, and taking the recommendations, I'm sure, to heart. And so I thank you for what you do. I was listening to some of the physicians earlier, and it is emotionally and it is psychologically draining. I'm in the room with some people who too, and I do, have to meet with families at their worst times to take tragic information. I get tired of walking through cemeteries, having carried behind me bodies of 15 and 16-year-old persons and on up who, and then their families are so broken, and they're going through the cemetery with me time and time again. And so I empathize with you, and I have much respect for you. A few questions that I did have, I'm not sure if those who could answer it have left already. But I was going to talk about cost for a moment. What's the hospital cost or estimated at least for each uninsured person who comes in with a gunshot wound or a stabbing, et cetera? I don't know if anyone can answer that. And you talked about therapists, and I know that what you're saying, there's not enough therapists, little money to relocate people, money's a problem. And I wanted to know, I was interested in what some of the main funding sources were, particularly from the private sector or the government sector. Is it even? Do you have, you never have the money that you need, but in terms of some of your funding sources, what are they? So that was the second question. And just the cost, because most of those who come in, you said, are uninsured. That has to take its toll on the hospital as well. And we're just interested in if there was any estimated cost per individual. So that was it. And thank you very much for that.
I don't know if we have any
know,
hospital administrators here.
Yeah, you don't
Anyone
know.
want, if not, we'll take it for action. I'll make sure we run it up the chain.
Thanks.
Sorry, yep, go ahead. Yes, come on up.
Good afternoon, Chairman Smith and committee members. For the record, Jennifer Witten here representing LifeBridge Health System. So I don't have all the facts and figures, Senator, but what I would say, at least from LifeBridge's experience, from the hospital perspective, if someone comes into our facility that's uninsured, then we have charity care policies, and we have Medicaid and other programs that help somewhat offset some of those costs. But as I'm sure Dr. Escalea would share, making sure that we manage trauma facilities is fairly expensive, because we need to make sure that we have all of the right physicians and other resources available 24/7. What I would say is kind of unique about some of the programs that you heard from Center for Hope and from our folks at Hopkins, and I'm sure at the university, is that a lot of those programs where we're doing that community hospital intervention, often those services are funded by grants. And so we work with the Office of Crime Prevention, we work with the Department of Justice, we apply for several grants and initiatives. A lot of those services are not reimbursable. We know that the state is applying for some funding that we might be able to get some of those services reimbursed by Medicaid through crisis services, but it's a very small portion of the work that we do. So I think that's an area as we further explore and really think of this as a public health crisis, that we'll have to kind of lean in and identify where those sources can come from. So hopefully that gives you some perspective of some of the funding sources that we tap into for these programs.
Most are government sources. The grants are government driven and supplied,
Correct.
et cetera, et cetera.
Correct. Yep. Government, I would say philanthropy funds
yeah.
a lot of those initiatives. So I'll turn it to the good doctor here.
Thank you much.
It's just highly variable. Like some people that are victims of violence are not terribly injured, and they are in and out of the hospital quickly. But some are very, very badly injured, and the costs of their care go on. You know, if you are a gunshot wound with a spinal cord injury, your need is the rest of your life, or with a severe traumatic brain injury, that need is the rest of your life. And so you add all of the costs for the trauma centers in Maryland and add up the uncovered costs, and it's millions and millions and millions of dollars.
Thank you. Thank you very much, both.
Again, I don't have any answer regarding the funding,
Yeah.
but in terms of the relocation, you had
Yes.
mentioned relocation.
Yes.
What we do with our high-risk patients that come into the hospital, when we consider high-risk patients that come in as a result of GSW, may be gang-related, maybe exchange of gunfire, and the individual may be a target or something similar to that. What we would do as a violence intervention, especially if we reach out to the mayor's office, Muncie, with Mark being our contact there at the mayor's office, and also the director of ROCA, Anisha. Basically, we will communicate with both those partnerships and explain the situation. because quite often there's been situations that we've had patients that need to be relocated within a matter of 3 and 4 days. Why? Because they were still being threatened, drive-bys, intimidations, and even gunshot wounds. So it's just been a collaboration between the mayor's office and local organization that assists us with relocating patients. So the funding aspect, I have no idea.
So when you relocate them, whenever you have to relocate someone,
Mhm.
you send them to a place, you help them with housing. How much or how long do you follow up with them with financial assistance?
Well,
Are you able to do that?
Okay, well, in terms of the relocation, once we consider it's a warm handoff. We provide the receiving organizations such as ROCA
Right.
with all the information that we have, that we take from law enforcement, that we receive from the hospital clinical team, and pass that off to ROCA. And the relocation, we don't know the relocation in terms of
Right.
destination.
Right.
Sometimes it can be local, it can be out in the county, sometimes it can be out of state.
Right.
And so that funding aspect is provided by those organizations and not by us.
Okay, that helps me. Thank you. Thank you.
Thank you, Mr. Chair. As long as we have Dr. Scalia here, I'd like to ask you a question. In your excuse me? So in your presentation, you gave some statistics, which I thought were stunning, that if Baltimore were just as dangerous as Chicago, we would have only about 160 homicides per year. And even if last year's number was a blip, it's still several multiples of that. So I was trying to figure why Baltimore is so much more dangerous than other cities, Chicago in particular. I think it was Dr. Webster who said that most Baltimore gun victims are high school dropouts. I think he said all but one in your experience were high school dropouts. Can you draw a one-to-one connection between the terrible rate of homicides in Baltimore and the difficult situation of the city school system?
I am not the right person to answer that question. But others here or others in that sphere are probably better than me. Why Baltimore? I don't know. But it's been for decades. This is not something that happened a year or two ago. And so the problem has been long-standing.
Yeah, ever since I wasn't wearing seatbelts.
Pardon me?
Ever since I wasn't wearing seatbelts.
Well, yeah. I mean, it has been a long-standing issue in the city, and I will join voices with others that what we have done is we have attempted to Band-Aid the problem. And I don't mean to, people that are looking for a 1-year or a 2-year solution, that is not durable. This is a generational problem. And if we're going, in my mind at least, if we're going to actually solve it, we need to dig in for the long haul, not for the short haul, and commit to solutions that are going to train young people to come up and have better opportunity and not be victims as they are now.
Thank you so much for your insights this afternoon.
Senator West, I say hold on to that thread for tomorrow's briefing where we're going to have chronic absenteeism and truancy. So hold on to that thread. So we've got Senator Sidnor, then Senator Fulton.
Thank you very much. I had maybe 2 questions. The first is for Dr. Webster, I believe. And in the time that you're Center of Gun Policy and Research, I'm curious, have you or any of your researchers figured out a way or have any policy suggestions on how a state that is interested in addressing gun violence but stymied because of that Tiahrt amendment at the federal level, are there policy solutions of attempting to get around that when we're attempting to figure out where these how gun trafficking may be happening in one state?
Yeah, so very briefly, just so everybody knows what we're talking about, TR amendment is something passed by Congress back roughly 2 decades ago that restricts the government's release of information of how guns make their way to someone who shouldn't have them and crime scenes. I've done a lot of research with crime gun trace data that actually literally connects the dots between some of the problems and also helps identify some of the solutions. So I view that as a really important constraint on understanding what's going on, and sort of again gets back to the heart of the message I wanted to convey, which is data is really powerful here. To understand the root causes that we were just talking about earlier, but also to understand how guns flow from one place in a legal context to an illegal context. I do think that despite the TR amendment, I think we can and should do more with our trace data than what we currently are doing. I hope that New Jersey, for example, is a state where they coordinate with their local law enforcement agencies, pool trace data, because guess what? One city's gun trafficking and gun violence problem is very similar and connected to the one next door and so on. So I do think that it can definitely illuminate things. We do know that when Maryland started to strengthen its laws, particularly in 2013, we started to see a shift of guns coming from other states to circumvent some of the restrictions put in place here. But again, those things can be really pinpointed to identify potential traffickers, and I've studied many cases where the data there, they can help you solve the problem. And we shouldn't have the restrictions in Congress, but even with those restrictions, we could still do more than what we currently do.
And you said you have some research or some policy solutions that.
On just generally on gun violence, is that what? So many of the things that we've studied, Maryland has adopted. Gun purchaser licensing is a very effective policy. Safe storage, we've covered some recent bases. We've finally started with some legislation on privately made unserialized firearms. So I think we've covering a lot of bases. I do think that we should examine the enforcement of those measures. And, I'll give you an example, actually, something very troubling as I'm preparing for testimony today. And I was looking at the FBI background check data for the past 5 years, and they break down those background checks for whether the transaction was between private individuals. Of course, in Maryland, if you're going to sell a handgun from one citizen to another, there has to be a background check. That's the law that was passed here. Over those 5 years that I looked, the most of private background checks in any given year was 12. That was last year. There were some years where there was 0 that were recorded. Now, maybe these aren't being recorded correctly. I don't know. But I will tell you that having looked at some of the data on prosecutions, that it's incredibly rare that law enforcement addresses, again, this sort of pipeline and sort of the supplier part of this problem. Mm-hmm. We pass laws, but we are not often enforcing them.
Thank you very much.
Sure.
And the other question that I had, I think Ms. Whitten touched on this, but it's open to anyone from the administrative side. In 2022, we passed Chapter 505 dealing with violence, intervention services and things in Medicaid. would anyone mind sharing with us the state of where things are now in terms of Medicaid? I do know this summer, the Department of Health had put forth proposed regulations, which I attempted to have them modified because they took out folk who were not hospital affiliated, which was not the intentions of the legislation that we passed.
Yeah.
So I'm curious to hear what's happening now.
It's interesting because there's a bit of a gap. In order for folks to be credentialed to do this, they have to be trained. There's not enough training opportunities for those folks. And, billable service and coding and all that stuff, really, at this point, we're allowed to do it connected to a hospital. And so the process is moving, but it's moving extremely slow. And we're looking at some of the reasons why. So LifeBridge currently is in the process of trying to start that system. And in order to do that, we have to have folks who are ready to do it. And our systems have to be prepared to do that. And so that's some of the holdup. So we've been working with the HAVI, which is the Hospital Alliance who is seen as the only credentialed training opportunity. And so as a nonprofit, Center for Hope, we're looking at, yay, we would love that, but what else can we do to train enough staff to be able to do that? Because the billable service option is going to help us with some sustainability. And so, with Connecticut, they're a little bit farther along than we are. So we're working in partnership with them to see how we can speed up this process. There are some gaps.
That was with Dr. Fisher at Ivy.
Yeah, absolutely. So, and if you need, I can follow up some more for you and get you a more concrete answer. But that is where we are as a hospital.
How about the University of Maryland? Is anyone able to speak to Maryland? Anyone from the University of Maryland? I'm curious how if this new law and the proposed or the regulations are affecting those types of violence intervention services and Medicaid.
That is out of my scope. But I'll be happy to get the information and get it to you.
Sir, I can confirm we're in the same boat with Center for Hope. So we're going through the training, the required hobby training currently as we speak. So similar positions, but we look forward to and appreciate the support of the legislator getting that passed.
Thank you.
Yeah, it's unanimous at Hopkins. Certification training is next week. And so once we get that, we hope we will be able to work with our compliance office and take advantage of that.
Thank you, Mr. Chairman. Dr. Scalia, if you would mind coming up one more time. Gonna get your steps in today.
Yes.
So Dr. Scalia, first of all, I just want to say, I mentioned something in the back and I feel like an obligation to really, as someone that has been collaterally affected by your team's work, with my two coworkers that were shot on February 11th. Amazing work. Everybody on my squad's extremely grateful to you and your staff sending them home. So amazing. And you know how blessed Brian is to survive that. You made a really compelling, I guess, phrase at one point when you said that, some of the things that we're dealing with here are consequences of life circumstances, and the way that kind of the generational, you even followed up and you came up the next time and you talked about some of the generational problems that we're facing as a society, really. And some of the solutions, we've tried to look at, I know that obviously this is something, and I guess I'm just asking in the form of, this body looks at different things, but we see them sometimes in a slightly different lens on how we find that solution. And, truancy, staying in school, not passing kids along to the next grade just to get them up and out of their grade with failing English and mathematical scores by the time they're graduates is not a solution to make them an effective contributor to society and continue to, move up out of this problem area. Because, I can tell you, like last Friday, I was at work and we had 2 shootings at Poppleton 27 minutes apart. I mean, it's just around the corner from the university. This is something that's not, we're seeing the increase. The numbers are up early this year. We've got a wonderful resource of wraparound services that we just seem to not be able to fit that piece in somewhere early enough to facilitate an effective solution for this. So I guess what I'm asking is unfortunately the amount of death I've seen, and yours goes well beyond that. You're trying to save people that are coming there with life-threatening injuries. And I know that little piece that you talk about, every time, and you still come back and we battle back and you battle back and you still want to be find that positive outcome. We always want to find that one. And then it always makes it, brings you back a little bit of life. The solutions that we're seeking are the same, but we're not getting there because we stop short of some of the accountability measures and how we are, and this is going to be a follow-up also for Dr. Webster, is we have a perpetual issue that we've kind of reeled back on the accountability part, and in a lot of ways, and I'll just use my word, enabling a certain mindset that is a failing mindset in some of our youth. So in these life circumstances that we're talking about, is there anything that I'm missing, like the truancy, the staying in school, these things, getting involved with these wraparound services at an earlier age to really try to contact these kids? Because that's what we're seeing a lot of. We're seeing a significant increase in juvenile related gun violence. They're not old enough to buy a gun. They're not obtaining them legally, but there's no consequences that are significant to deter when they're talking about trying to, in some cases, literally defend themselves for their lives.
Yeah.
It's a lot. I apologize.
Yeah. The easy answer is I don't know. I reflect and realize that many of the violence intervention, hospital-based violence intervention programs, in order to get enrolled in them, you have to be injured.
You have to be shot.
It's a little late.
Yes.
And it seems clear that this is a process that needs to start at a very young age, not when you have learned behaviors. That makes some sense to
Or
me.
have already been shot.
Yeah,
Right.
I suppose that's true. And I maybe this is simplistic, but when I grew up, I didn't worry about being shot. I went to school.
Right.
That was my mom. I had a family and
Right.
With a fairly, nice structure to it. And so I can't imagine what these kids go through as they try to negotiate their young years, to get to where it is they're going to get to. But, they don't, when I grew up, I wanted to be, I'm so old, I wanted to be Duke Snyder, right? I wanted to play center field for the Brooklyn Dodgers. And kids are kids. The kids that are growing up in the city, they want to grow up, and be
They have
LeBron
dreams.
or
Yeah,
I don't know who it is
Sure.
now, right? Steph Curry. But it doesn't, I didn't get to play ball for the Brooklyn Dodgers, but I did okay.
Yes.
And so now what specifically we need to do, there are many, many, many people working on that. And that is when we set up the Maryland, it's the Center for Violence Prevention, not Violence Intervention,
Mhm.
because that's what we need to do. We need to not fix the problem. We need to prevent the problem from happening.
Thank you. Appreciate it. And I just have a follow-up for Dr. Webster, the same type of thing. So I just, along that line, and keeping that in mind,
Yeah.
I'll just go ahead and kind of throw out a couple of these little
Sure.
other margins, and you can just
Okay.
kind of address them all at once. But the other areas, the other states that you go to, are when it's like theft of handguns, are those felonies in those states? If somebody goes in and breaks in and steals a handgun? I mean, and the reason I'm asking is that's statistically, it's an important thing for the consequence part of it.
Sure. So if you are, depends on the value of the gun. It depends on
You break in
whether-
somebody's house and you're
Oh,
committing
break
a
into
felony.
somebody's house. Yeah,
and-
that's
and you
going to
take a
definitely
gun,
be a felony for
It's
sure.
a felony.
Yeah.
Okay.
A lot of what we're seeing most recently is more and more guns stolen from motor vehicles.
Yeah, so that's what I was gonna say next.
Yes.
So if you don't break in somebody's house because it's a felony, you go in and break in their vehicle, breaking in the vehicle, taking the gun, it's a felony in those other areas still?
I don't know. I haven't looked at that.
Okay. And then, some of these measures I hear you bringing forward, and look, I appreciate and I'm grateful for all your guys' work, all the solutions you seek. Again, I think some of these solutions are missing the intended target though. The intended target is to find a way to prohibit, especially the young gun possessors and users in violent acts.
Mhm.
And none of these solutions, other than I think, and I was supportive of the Gun Safety Act with, by being able to help out and give safes and put a lock on it. But every one of these come after legal gun owners. And it's not hitting the problem of the illegal gun owners. And this is the part that I think that I would love to see your program really get into, the nuts and bolts and the solutions of remedying that, because everything that comes forward from your group targets legal gun ownership. Even the statistic that you brought up, the person-to-person sale background checks, that's because in the state of Maryland, they go to an FFL and they literally hand it to the gun store owner or
Yes,
the
I know.
person,
Mhm.
and then they reassign that. So that's why this is an issue that I can't go and sell you my gun and say, hey, sign this paper here.
Yeah.
You can't do that. It has to follow the course that is set forward in law.
Yes.
So, and these aren't the guns that we're seeing repeatedly showing up on these scenes with serial number scrubbed and all that. When they're stolen, we do see them. And I'm not saying that there aren't bad actors in any group, but overwhelmingly we see illegal guns in the hands of prohibited persons involved in acts of violence against others, whether through theft, fear, robbery, or engaging them with that weapon and shooting them. And none of the solutions I've heard from your group are coming after that. Like Dr. Scalia was talking about, like I was trying to talk about, which is the portion in the beginning before it gets to that. There's no solutions in there for you guys on that.
Well, look, we've studied gun policy and the connections between legal and illegal markets, and there is a clear connection. And so yes, you do have to regulate legal markets to minimize the leakage, so to speak, into underground markets. We know requiring safe storage reduces theft and diversion into the legal market. It actually also reduces juvenile commission of homicides. Good study on that. So there's a lot of measures that are, yes, they require certain things of people who sell and purchase firearms, but it's a mechanism to reduce the diversion within the underground market. In my own studies, actually, we look using the trace data that I was referring to a few minutes ago, the guns that very quickly go from a retail sale to involvement in crime with someone who wasn't the purchaser of record. Clear straw purchase kind of scenario.
That's a crime in and of itself.
It
Yes.
is. And what we find is that there are policies that actually make it more of a deterrent so that you don't commit that straw purchase.
Correct.
Make that
But we
diversion.
have those deterrents in place now, and that's kind of my point. I'm not talking about those legal gun ownership where there's a straw purchase. But I understand that, right? Because now the legal gun owner doesn't want to be involved in a straw purchase because there's consequences that could affect them for life. What I'm talking about is when someone goes in and they break in a car and there is a gun in there in a center console or something, that they see that gun and they're like, oh, I'm going to take this because there's no consequences here. It's a misdemeanor. There's not, the device itself is the threatening, is the tool. Right? That is the tool. The weapon is the person. The gun is just a tool and an extension of that person if they're willing to do that. So I would like to see some of your studies and if you have some, great, send them over. But I'd like to see some of the information that you have on these things, because in Maryland, you can steal that gun and it's a misdemeanor. What are we teaching people? It's okay to don't steal an iPhone over a certain value because that's a felony. By golly, don't do that. But the gun, it's only worth like $700. It can kill people, but don't worry about that.
Well, sir, we're on the same page here, okay?
I figured we would be. I just want to get to the preemptive part.
It's a very serious thing to steal a firearm.
Absolutely.
For all the reasons that you just articulated.
Thank you.
So I'm not against you on that, sir.
I look forward to working with you on that. I would like to see you guys get involved in a little bit more of the leading into before we get to that point with some of these juvenile offenders.
Okay.
Thank you.
Thank you, sir.
All right. Didn't take us long to get back into the swing of JPR last couple of days. You know, it's good. So one thing I like about the briefings is that we don't focus on one particular policy, but you kind of evaluate systems, identify, things that are working and things that are not working, gaps, and then offer solutions to kind of figure that out. And so one of the questions that I had was just a lot of people talked about the continuum of care. And so I guess, Ms. Lepley, you spoke a little bit on this. I'll ask you the question can you just describe to us from kind of point of treatment and Dr. Scalia too, and Doctor, you come on up if you want, but point of someone comes into the trauma center, they're treated, patched up, okay, stabilized, then they go back into the community. Then what? I mean, they're gonna have some sort of a physical ailment that could last the rest of their lives, but then also they're gonna have some psychological other supports and needs. What is done outside? And then can you just speak to some of the criminogenic attributes of a gun violence victim and their propensity, if any, to be the perpetrator of gun violence? Because then you're turning, kind of a crisis into an opportunity to insert yourself into a conversation, get into the community, and then maybe prevent further gun violence. If you could just talk about the continuum of care and some of those touch points, and then what happens after someone leaves the hospital, and if there's anything we can kind of in the legislature can be thinking about to support, kind of plussing up, your work in the community.
Thank you for the question. So certainly from our perspective, the mall entrance into healthcare is the emergency department. And the continuum of care extends way beyond the acute care episode. That could be a few hours in the hospital. It could be months in the hospital. At Johns Hopkins, we see about 60% of our gun violence victims are treated and released, which is great. We have non-fatal injuries, but our work extends not only during that acute care phase, but into the community with intense contact with our victims almost on a sometimes weekly basis, if not more frequent. To address not only their emotional state, their physical state. We're working through trying to make sure that they have good follow-up with their healthcare providers and timely access to those providers. So we're working through a lot of care coordination issues, and we're also trying to help them navigate systems, victim services programs, things of that nature that they can have a benefit for, but also trying to get them connected with community-based programs to help them longitudinally make different decisions going forward and give them a toolkit of supports. Because the community, their families, their peer groups may be ill-equipped to be able to meet those needs. So, and many times we're life coaches, and our care across that continuum will extend into a year in terms of our follow-up. And so that's a huge expense for us because certain things come up during that year that we didn't anticipate or identify as risk problems. But we work cooperatively with government agencies, with healthcare providers, and our community-based programs that Freedom mentioned to make sure that they do have those supports. Right now, we are funded through in-kind support for these initiatives with our hospital, but certainly in the past, we've had to take advantage of ARPA funds, the American Recovery Act, that came through us through the federal government, and do have access to acquire those funds again in the coming year. So yes, it's very expensive, it's very intensive, but we think it's worth it.
So absent funding, because we don't have power of the purse in this committee, like, are there any like regulations that are being implemented that shouldn't be? Are there any roadblocks, hurdles to delivery, to you know, expanding? I mean, those are some of the things I feel like we
Great
have a blind-
point.
Yeah.
Right now, those ARPA funds for our hospital-based programs are just 2 years. They'll end in June. So it's really about where do we go from here to help us support this valuable work going forward.
Excellent. Further questions from the committee? That's a first. All right. Good deal. All right. With that, then we'll conclude the briefing. I just want to again say you all have extremely important lives and work to do, and really appreciate the time that you've spent with us, educating us and the citizens of Maryland, and for the work that you do out in the community. Really appreciative of all of your efforts, and just want to say thank you very much for taking the time today. This is great. All right, that's it.